Hey, it's 12 noon Manila time, and it's time for the 19th Lourdes Manahan Lecture in Rheumatology. We're now streaming live from the University of the Philippines in Manila. Again, I am Dr. Heizel Reyes of the Division of Rheumatology here at UPPGH, Department of Medicine, to moderate this section. I would like to thank our sponsor, um, Johnson & Johnson, and all of the participants for joining us all today. We now see that we have 281 participants already in our meeting. So we look forward to having you until the end of this session. For this meeting, you can post your questions at the Q&A box, and we will address them during the open forum. If you're a bit shy, there is a box in the Q&A that allows you to send your question anonymously. You will receive your certificate of attendance a week after you submit the evaluation form and the post-test. The link to these will be posted later. So this is our 7th of our 8-part LMLR webinar series for this year. This series aims to teach the basics and also provide updates in rheumatology. Continuing advocacy from that has been initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. LMLR is in support of the Sustainable Development Goals 3 for health and well-being, and SDG 4 for quality education of the World Health Organization. The division is also happy to share with you the publication of its book, as mentioned by Dr. Añanuevo, The Atlas of Rheumatic Diseases in the Philippines. Those of you who may wish to avail of this book may email pgh.rheumatology@gmail.com or message us via Viber or SMS at 091-925-808-3573 or scan the QR code on the screen to place your orders. We also have another publication that's already out, which is the Physician's Guide to Telerheumatology. This is a toolkit for non-rheumatologists on the approach and the initial diagnosis and management of various rheumatic diseases. You can also message us through the same numbers to place your orders. However, our lecture for today will focus on ankylosing spondylitis, and we're very glad to be joined by two very good speakers. Our first speaker is very close to our hearts, Dr. Patricia Pauline Remalante-Rayco. She completed her education and training in internal medicine and fellowship in rheumatology at the Philippine General Hospital. She's now joining us from the Toronto Western Hospital, where she's in a undergoing postgraduate training in their spondylitis program. So she's really decided to focus on this specific condition. Dr. Remalante-Rayco is an associate professor of the College of Medicine at the De La Salle University Health Science Institute, but I expect that she will also join our faculty when she gets back. Our second speaker is Dr. Cecilia Tiangco. She completed her residency training in rehabilitation medicine at the Philippine General Hospital. Dr. Tiangco serves as the vice chair for the residency training of the Department of Rehab Med in UPPGH and is also the chairperson of the Department of Rehab Medicine in Manila Doctors Hospital. Ladies and gentlemen, colleagues and friends, let us welcome Dr. Remalante-Rayco and Dr. Tiangco as they share their expertise in today's lecture in preventing disability among patients with ankylosing spondylitis.
Thank you, UPPGH Division of Rheumatology, for the opportunity and honor to be part of the Lourdes Manahan Lectures in Rheumatology. I've been tasked to talk about the therapeutic approach to preventing disability in ankylosing spondylitis, or AS. I have no financial conflicts of interest related to this work. We now know that axial spondyloarthritis, or AxSpA, more commonly referred to only decades ago as ankylosing spondylitis, or AS, is one of the most common types of arthritis that affects predominantly the spine and the sacroiliac joints, which are part of the axial skeleton. Uncontrolled inflammation in AxSpA can lead to new bone formation and deformities of the spine, but this inflammation can also occur outside the spine and involve the enthesis, where ligaments and tendons attach to the bone, the eyes, the gut, and the skin in the form of psoriasis. AxSpA encompasses both non-radiographic AxSpA and radiographic AxSpA, which is the same as AS for all practical purposes. We have found out that not everyone will inevitably have fused sacroiliac joints and bamboo spine. In fact, only a small percentage of patients will progress to AS in 2 years, likely those with certain factors that we will talk about later. Non-radiographic AxSpA and AS may have some demographic and clinical differences, as you can see here. But when we look at the health outcomes like disease activity, functional status, their quality of life, and their productivity at work, we see that they have the same degree of disease burden, and not one group is suffering less than the other. Exploring the relationship among these different health outcomes is not new to chronic diseases like rheumatic disease, as you can see in the International Classification of Impairments, Disabilities, and Handicaps of the World Health Organization. So according to the schema, a disease such as AxSpA, for example, gives rise to impairment, which is defined as any loss or abnormality of structure or function. In the context of AxSpA, impairment can result from pain, stiffness, and fatigue. Impairment may then lead to disability, which is any restriction or lack of ability to perform an activity in the manner or within the range considered normal for a human being, such as when AxSpA patients require assistance just with putting on their socks or pants, or they need to hold on to railings just to be able to pick up something from the floor, or simply standing unsupported for 10 minutes without difficulty. Impairments and disabilities, by interacting with the physical and social environment, can then result in handicap, which is a disadvantage that limits or prevents the fulfillment of a normal role, such as doing household chores or being able to work without difficulty or interruption. And then at the end of this continuum, we can find quality of life, which is a broader outcome that can be influenced by a series of contextual factors like the patient's environment and personal factors like age, sex and gender, ethnicity, self-esteem, and coping skills. Health-related quality of life reflects the overall impact of the illness and its treatment, not just on the patients, but also to the people around them and how these people respond to these impacts. This stratified model for health outcomes in AS suggests that health-related quality of life is the highest in this hierarchy and that all the other domains contribute to it. Disability directly relates to physical function, but this can also be influenced by one's mental or emotional state. Knowing that physical function and hence disability are independently determined by all the domains underneath it, as you can see in this diagram, it makes sense that controlling the signs and symptoms of AS caused by spinal inflammation, especially with treatments that can modify the course of the disease and retard structural progression through pharmacologic and non-pharmacologic means, can help us address disability in AxSpA and improve a patient's quality of life. And that introduction brings me to my task today, which is to discuss therapeutic targets for AxSpA. And Dr. Tiangco will lead the discussion on physical and occupational strategies in the management of AxSpA. So just as an overview, I will be discussing the therapeutic approach, first for signs and symptoms of AxSpA, and then for disease modification, and then the future of AxSpA therapeutics. We can see that relative to rheumatoid arthritis, which is on the top row of this illustration, axSpA has a more limited treatment armamentarium, but the point is there are actually medications that can help control signs and symptoms of the disease. And before we forget, NSAIDs still are the first-line treatment in axSpA, and it's not a thing of the past. It is the cornerstone of treatment, and any patient with active disease who can tolerate and has no contraindications to NSAIDs should be treated with these medications. Conventional disease-modifying anti-rheumatic drugs, or what we call DMARDs, are part of the rheumatoid arthritis list here, but they also have adjunctive use in axSpA, meaning they're used in specific circumstances. They're useful especially if the patient has either predominant or significant peripheral joint involvement, although we still see them being used for axial disease in regions with limited access to biologics, despite very weak evidence for any benefit. Systemic steroids have very limited use, such as for flares during pregnancy or for patients with severe flares who are intolerant of other medications. Intra-articular steroids are, of course, a different story because these are very useful for mono or oligoarticular peripheral arthritis or even sacroiliac joint injections for those with very localized pain. Biologic DMARDs and small molecule therapies are given after NSAID failure, and these are more specific anti-inflammatory therapies in that they target specific cytokines and small molecules compared to the broader anti-inflammatory effect of NSAIDs. TNF inhibitors are the mainstay of biologics, and the IL-17 inhibitors are rapidly becoming at par with the TNF inhibitors. And then the JAK inhibitors are sort of the new kids on the block, so we will go through them one by one. We all know what NSAIDs are, but is there a best NSAID? Here's a network meta-analysis looking at 26 RCTs on short-term NSAID trials that were given only for 2 to 8 weeks, where they compared 20 different NSAIDs with placebo, and the primary outcome being measured here was pain on a visual analog scale. So in the figure, the green line represents 0, which is the point of no difference, and each horizontal line represents one NSAID. The further the horizontal line is to the left of the green line, the better it is in decreasing pain than placebo. We see that many of the commonly prescribed NSAIDs are among the most effective, and they were given here in their full or maximum doses. Etoricoxib, which I will mark with a star, outperformed all other NSAIDs. It's available in the Philippines and is a favorite of mine and many of my patients, but it's not approved by FDA for use in the US, and it's also not available in Canada due to concerns about cardiovascular toxicity, which I will be returning to in a while. And then indomethacin was originally thought of to be one of the most potent NSAIDs, but we can see here that it's not more effective than naproxen or diclofenac, but it performs just about the same. So the message is etoricoxib appears to be the most effective NSAID, but it's not without risks, but the other commonly prescribed NSAIDs are just at par with each other. So if there are no contraindications, we usually start patients using the maximum doses on a continuous or daily basis rather than as needed, so as to put out the fire of the inflammation. But I find that many physicians and patients can be hesitant about using NSAIDs, and of course their concerns are not unfounded. Speaking of side effects, the same study team did not detect differences among NSAIDs, at least in the risk of total or gastrointestinal adverse events in these very short-term trials. But of course, larger studies with longer durations are needed to provide better estimates. Just of note, cardiovascular side effects were not assessed here, but they're quite important because AS patients are at an increased risk of cardiovascular events in addition to traditional cardiovascular risk factors. So here is another meta-analysis, this time of observational studies on the risk of myocardial infarction, or MI, with NSAID use versus non-use. So this included just the general population and not just AS patients. So the green line here is again the point of no difference, and the higher the lines are above the green line means greater risk of MI. And you can see that almost all of the NSAIDs most frequently used in practice, except naproxen, were associated with an increased risk of acute MI, and MI was represented by the lines in red. And I marked with stars those with the highest risks, which are diclofenac, rofecoxib, which has been pulled out of the market, indomethacin, and etoricoxib. And the risk was increased when NSAIDs were used at high doses or when used in persons with pre-existing coronary heart disease, of course. And this slide is not meant to further scare you from using NSAIDs. And as I posted on the upper right, the point here is that we should know how to use our NSAIDs judiciously and in an individualized manner. So in our AS clinic, for example, as many as 40% of patients are on NSAIDs without biologics. So what we do is we give them NSAIDs at maximum doses to be taken continuously for, say, the first 3 to 4 months if they don't have contraindications, and then we reassess their response. If they do significantly better on continuous NSAIDs, we allow them to decrease the dose by half and then eventually take it as needed. And whenever they encounter a flare, especially rare flares, meaning like once a year, then they can just increase their dose again. Interestingly, a study at our center found that in patients who are aged 65 years or older, a lack of exposure to NSAIDs was a significant factor for vascular mortality, presumably due to prolonged systemic inflammation leading to vascular disease. And as Dr. Penserga used to tell us when we were training, you have no reason to be afraid of NSAIDs if you know how to use them properly. Now we go to the biologic DMARDs, and the first of which are the tumor necrosis factor alpha inhibitors. TNF-alpha is a potent pro-inflammatory cytokine that was found to be central in the pathogenesis of many inflammatory diseases, including axSpA. And we currently have 5 TNF inhibitors approved for AS treatment, although I don't think we have certolizumab pegol in the Philippines. They may differ slightly in their structure, their half-lives, and then modes of administration, with infliximab being the only one given intravenously. In the succeeding slides, you may see me alluding to the assessment in Spondyloarthritis International Society, or the ASAS-20 and ASAS-40 criteria. These are commonly used in clinical trials to measure the change in global assessment, pain, functioning, and morning stiffness, which is an indicator of inflammation in response to a medication. So the only difference between the two is that the ASAS-40 is a stricter set of criteria and is therefore more difficult to obtain. So among the different TNF inhibitors, is there one that should be preferred over the others? Here is a line graph summarizing the different phase 3 trials of TNF inhibitors in AS, looking at the ASAS-20 response criteria, with the blue bars representing the TNF inhibitors and the orange bars being placebo. And we can see that in as early as 12 to 14 weeks, around 60% of patients receiving TNF inhibitors had an improvement in their pain, stiffness, and functioning compared to the 20 to 30% of patients who were on placebo, emphasizing our point that in terms of efficacy, there is no superior TNF inhibitors. But as you can see, even without treatment, up to 20 or 30% of patients improved on placebo, and it's probably because of the waxing and waning course of ankylosing spondylitis, or axSpA. So are there patients who are less likely to respond to TNF inhibitors? In this meta-analysis of 33 studies, they found that patients who are male, who had more inflammation at baseline based on their higher BASDAI scores or higher CRP levels in the serum, and those with a positive HLA-B27 responded better to TNF inhibitors, while those who were older and had more functional impairment, as indicated by a higher BAS-V scores, had poorer response to treatment. Older patients had pain from concomitant degenerative changes, which usually don't respond to biologics. That's probably why they responded poorer to TNF inhibitors. And of course, those with worse functioning probably were the ones who had established disease and already had radiologic damage, so they were also less likely to respond. So these are important to discuss with your patients so that you can set expectations early on. And if you don't see any response with TNF inhibitors, you won't be surprised. So in the more than 20 years of TNF inhibitor use, their safety profile has been overall favorable. Studies do not show an increased risk of serious infections with TNF inhibitors, and a study even showed that TNF inhibitor use was associated with a lower risk of severe COVID-19 outcomes versus other immunomodulatory treatments because the outcomes of COVID-19 result not from the infection per se, but from the resulting systemic inflammation. Majority of studies do not show an increased risk of malignancies compared to the general population, although there are studies showing an increased risk for non-melanoma skin cancer, specifically in rheumatoid arthritis. But rheumatoid arthritis itself can increase the risk for this cancer, so it's difficult to attribute it solely to the TNF inhibitor. Maybe it's from the disease, it could be from the biologic, we don't know. Moreover, it's difficult to extrapolate this to the AxSpA population. As for infections, it's important to screen patients for underlying tuberculosis or hepatitis because TNF-alpha maintains granuloma integrity, which we need to fight TB, and it also clears hepatitis B virus from hepatocytes. And finally, other possible adverse events associated with TNF inhibitors have less robust associations, but it's important to keep these in mind when selecting an appropriate biologic for your patient. Now we jump onto a biologic class with a different mode of action, the IL-17 inhibitors. To date, we have two monoclonal antibodies selective for the IL-17A isoform, namely secukinumab and ixekizumab, and both are available in the Philippines. The left graph shows the ASAS-20 response, while the right one shows the ASAS-40 at week 16. And we see that the ASAS-20 with IL-17 inhibitors are quite comparable to TNF inhibitors, with 60% of patients responding to the active drug compared to placebo. And because ASAS-40 is a stricter criteria than stricter criteria set than ASAS-20, it is expected that a slightly lower proportion of patients will meet this outcome. But I would like to direct your attention to the two ixekizumab trials, which are the last two lines in each graph. Sorry, I think I'm blocking the ixekizumab trials in the ASAS-40 graphs. But the first trial here included patients who had ixekizumab as their first biologic, while patients in the second trial included those who had an inadequate response to a prior TNF inhibitor. And you can see a slightly worse response among the TNF non-responders, and this reflects a more difficult to treat population who already had prior treatment failure and more long-standing disease. So those are the implications here. Okay, there are two other newer IL-17 inhibitors that have shown promising results for AxSpA in phase 3 trials. Bimekizumab blocks IL-17F in addition to IL-17A, and this has better effects on new bone formation, at least in vitro studies, while brodalumab is an antibody against the IL-17 receptor receptor A, which theoretically has a broader activity because it blocks the different isoforms of IL-17. Neither are approved yet for axSpA, but we see that for both drugs, around 45% of patients on the active drug had an ASAS-40 response, compared to just 20% in placebo on placebo at 16 weeks. Now, before we think that the these two IL-17 inhibitors were less effective than the TNF and IL-17A blockers, let's remember that the primary outcome that they looked at here was ASAS-40 rather than ASAS-20, and we expect only around 40% of patients to improve with stricter criteria. But this is still significantly better compared to placebo. The newest drug class among these targeted disease-modifying drugs are the JAK inhibitors, which act upstream of TNF and IL-17, meaning if you block the JAK pathway at a molecular level, it also allows regulation of many other cytokines. And it's also quite attractive to patients because they come in tablet form. So 3 JAK inhibitors have been investigated in axSpA to date, and these include the JAK1 selective filgotinib and upadacitinib, and the pan-JAK inhibitor tofacitinib. For these graphs, the lines in aquamarine on the left side, just to orient you, are the ones for placebo, while the purple, light blue, and pink lines represent active treatment. You can see 2 results for each drug, one for ASAS-20 and another for ASAS-40, respectively. Their efficacy is at par with TNF and IL-17 inhibitors, with around 60% of patients receiving ASAS or achieving ASAS-20 and 40 to 50% reaching ASAS-40, even in patients with non-radiographic axSpA in one upadacitinib trial. And this ceiling effect of 60% across TNF, IL-17, and JAK inhibitors is quite interesting. Tofacitinib is available in the Philippines for rheumatoid arthritis, but as far as I know, it is not yet approved for axSpA. In the US, both tofacitinib and upadacitinib are approved. Filgotinib, despite promising results, it has been pulled out from further clinical trials due to concerns about testicular toxicity, just in case you're wondering what happened to it. Knowing that these drugs control signs and symptoms, we also want to know if they have the ability to modify disease. These are 2 RCTs comparing the effect of continuous versus as-needed NSAID intake on radiographic progression. So on the x-axis of both, you see the cumulative probability of radiographic progression, and by that we mean formation of syndesmophytes and eventual spinal fusion, while the y-axis shows the unit change in MSAS. MSAS is the scoring system we use to measure radiographic progression. These 2 RCTs show conflicting results. The first one on the left showed that over 2 years, more patients taking celecoxib as needed had radiographic progression compared to those who were taking it continuously, while in the second study, which looked at diclofenac, showed opposite results, where the MSAS progression was numerically higher in the continuous group compared to the as-needed group, although it was not statistically significant. So the criticism was that celecoxib, or the celecoxib study, made use of celecoxib with a difference in the mean dose between the 2 groups that was rather small. So there was not much difference between the 2 groups in terms of the dose or the mean NSAID dose. And this probably does not reflect the pattern of drug use and may thus not be the best parameter to explain the radiographic progression observed. So in short, we need more studies to verify these findings. TNF inhibitors, on the other hand, have been shown to modify radiographic progression. On the x-axis, we show the delay in years in starting a TNF inhibitor, while the y-axis is the rate of the MSAS progression. This study from our AS cohort showed that patients who started a TNF inhibitor more than 10 years from the time their symptoms started were more likely to have radiographic progression with an odds ratio of 2.4. In this curve from the same study, the 20% of patients in orange who started their TNF inhibitors within 10 years of symptom onset had a much slower rate of radiographic progression versus the 60% who started their TNF inhibitors late, meaning the delay of therapy and the total duration of therapy were also important in determining the rate of progression. But based on studies that I won't show here anymore in the interest of time, it may take at least 4 years of TNF inhibitor use before we see any appreciable effect on radiographic progression. Given what we know now, how do we help our patients choose? TNF inhibitors are usually selected as the first-line biologic by virtue of our experience with this drug class, as evidenced by the green dots across all domains in the second column there, meaning it's effective for axSpA patients with peripheral and extraarticular manifestations. But I am placing a star there for uveitis because the TNF inhibitor etanercept has been associated with higher risks of anterior uveitis. As you can see in the third column, IL-17 inhibitors can benefit axial and peripheral disease and has evidence for delaying structural progression as well. They're very effective for psoriasis and are sometimes preferred as first-line biologics for patients with axSpA and severe psoriasis. But IL-17 inhibitors are not effective for IBD. Some studies also show an increased risk of uveitis with IL-17 inhibitors. So for the fourth column, we did not discuss IL-23 inhibitors because they failed trials in axial disease, although they are quite effective for psoriasis and IBD. And finally, the JAK inhibitors have shown efficacy in axial disease. So I replaced the axial disease there with the green dot because I think this table was made before the studies with JAK inhibitors came out. But we see that it works just as well for psoriasis and inflammatory bowel disease. But more studies are needed for uveitis because they haven't been around long enough for us to know their effects on both uveitis and radiographic progression. So unless there are contraindications to receiving a certain drug class, it all boils down to patient preference because efficacy and safety is the same. Most patients prefer subcutaneous biologics because they can be self-administered at home, but others may prefer infliximab if they have needle phobia and if they want to receive the drug less frequently because infliximab is taken every 6 to 8 weeks as opposed to every 2 to 4 weeks of subcutaneous injections. In the Philippines, cost is of course a very significant part of the discussion because biologics are unfortunately not covered by insurance and patients often pay out of pocket for these very expensive medications. Looking ahead, we still have questions that remain unanswered, such as whether TNF inhibitors versus IL-17 inhibitors, can they be regarded as being equal as first-line biologics? This will be answered hopefully soon by an ongoing head-to-head trial of secukinumab and adalimumab called the SURPASS trial. We need more studies to further elucidate the effects of IL-17 and JAK inhibitors on certain extraarticular manifestations. And we also want to know if there is still room for IL-23 inhibitors to be reconsidered, especially for very early axial disease. More studies on the effects of JAK inhibitors on cardiovascular and cancer risk, particularly in the axSpA population. As you may have heard about the black box warnings that come with the JAK inhibitors, and the side effect profile may affect the providers and patients' enthusiasm for this very good drug. And the data that we have so far from the side effects are mostly from the rheumatoid arthritis population. And lastly, the potential for use of biologic combinations, such as combining the integrin blocker vedolizumab plus a TNF inhibitor for axSpA patients whose IBD cannot be controlled by TNF inhibitors alone, or ustekinumab plus a TNF inhibitor for those with very severe psoriasis or IBD, because these biologic combinations have actually been used on an off-label basis, and they were found to be effective for certain patients. So as a part of our key messages, disability in expa can be addressed through prompt and adequate management of signs and symptoms with the hope of delaying structural damage and improving patients' quality of life. We have more therapeutic options for expa, and hopefully we can make them more accessible to our patients in the Philippines, because the difference can be night and day for them. But let's not forget that we can still offer significant help in the form of NSAIDs, physical activity, and smoking cessation even at the primary care level. And treatment should always be individualized with consideration for all aspects of the patient's disease, their preferences, and in our setting, the cost for these medications. Thank you for your kind attention.
Good morning. I am Dr. Anna Tiangco, and today I will be discussing with you how we can prevent disability in patients with ankylosing spondylitis through rehabilitation management. For my disclosure, I have no actual or potential conflict of interest in relation to this lecture. My objectives for today are: 1, to introduce to you the ICF framework and its core sets in AS, and 2, to give an overview on the rehabilitation interventions used to address functional disabilities in these patients. Ankylosing spondylitis, or AS, is a chronic inflammatory disease causing axial arthritis, frequently resulting in inflammatory low back pain. This can also be accompanied by peripheral arthritis, enthesitis, uveitis, psoriasis, and inflammatory bowel disease, adding to the burden of the disease. Patients with AS have reduced quality of life. In a meta-analysis by Yang et al., they reported that the impact of AS on quality of life is greater than that of type 2 diabetes mellitus and similar to rheumatoid arthritis. A major component of this, as well as an important health outcome for patients, is functional ability. From the point of view of physical and rehabilitation medicine, the spectrum of problems affecting the functional ability of AS patients can be defined by the International Classification of Functioning, Disability and Health, or the ICF. This framework endorses the biopsychosocial model while recognizing the influence of contextual factors on functioning and disability. It is useful for structured identification of disability in a particular condition and for a particular patient, as the diagnosis itself does not reveal what the patient can do, the prognosis, or the cause of rehabilitation. ICF includes the following domains: body functions and structure, activity, participation, and environmental and personal factors. Body functions are defined as the physiological and psychological functions of body systems, while body structures are the anatomical parts of the body. Activity is the execution of a task or action by a person, while participation refers to the involvement of a person in everyday situations and in society. Contextual factors can be environmental, which make up the physical, social, and attitudinal environment in which people live, or it can be personal, the particular background of a person's life and living situation, and comprise features that are not part of the primary health condition. Comprehensive and short course sets of ICF have been developed specific for AS, and this aims to represent what is typical and relevant for functioning and health in this condition. In Table 1, see that within the body functions, the majority of identified categories belong to the sensory functions and pain, as well as neuromusculoskeletal and movement-related functions. For body structures, those related to movement are the most commonly affected. Activities and participation were grouped together and majority of the issues identified involve mobility and self-care. While among the component environmental factors, most belong to products and technologies, as well as services, systems, and policies. If we try to apply this to a patient, the ICF diagram will look like this. Under impairment of body structure and function, we can have pain, stiffness, fatigue, and limitations in spinal mobility. This would result in a variety of limitations in activities and restrictions in participation in life situations. Then we have the contextual factors, which can either be a driver or a barrier with regards to function. And so, how can we prevent these functional disabilities? What rehabilitation interventions can we offer? Rehabilitation management should be initiated as early as possible. The primary goal of rehabilitation management is to achieve the best possible long-term health-related quality of life. This is done through the control of symptoms, prevention of structural damage progression, and preservation and improvement of functionality and social participation. This is best achieved through a multidisciplinary approach. The rehabilitation team usually consists of physicians who are specialists in physical and rehabilitation medicine and other specialties, physiotherapists, occupational therapists, clinical psychologists, nurses, orthotists, and social workers, with the patient and his or her family at the center. Team members can be expanded or reduced depending on the needs of the patient. At the onset, patients with AS and their families need to be educated on the nature and course of the disease, possibilities of self-treatment, conservative and surgical treatment, and the importance of modifying habits and professional activities, including the use of aids. Proper education helps them to adjust emotionally, set realistic expectations, adhere to rehabilitative management, and prepare for community reintegration. PT interventions include postural awareness, therapeutic exercises, physical modalities, and assistive devices. Maintaining proper posture is especially important for patients with AS. It has been found that trunk muscle strength decreases, especially in patients with syndesmophytes. This is more profound in extensor than in flexor muscles. Thus, patients should be advised not to spontaneously stand or sit in a flexion posture, even though it reduces pain. Regular change of body position, stretching, and postural control are recommended. Therapeutic exercise is the most important non-pharmacological intervention in patients with AS, having both a preventive and therapeutic purpose. Therapeutic exercise should be prescribed individually for each patient, depending on the current disease activity and functional status. The prescribed type of exercise is usually a combination of stretching, range of motion, strengthening, exercises for improving posture, breathing, and aerobic exercises. Shortening and tension of muscles are most prominent in the sternocleidomastoid and trapezius muscles, shoulder adductors and flexors, hip adductors and flexors, hamstrings, and triceps array. These muscles should be the focus of stretching exercises. Range of motion exercises include those for the spine, chest, and limbs, with emphasis on the hips and the shoulders. Strengthening exercises, on the other hand, target the anti-gravity muscles, namely the spine extensors and gluteal muscles, as well as the lateral trunk flexors and trunk rotators. Breathing and aerobic exercises are very beneficial in improving exercise tolerance and pulmonary capacity. With regards to intensity, generally, it is important to start such a program at low levels of load, then gradually increasing its intensity and duration. However, with increasing interest in high-intensity training, an article was published on the British Journal of Sports Medicine in 2020 on the effect of high-intensity exercise in patients with axial spondyloarthritis. In this study, exercise was conducted 3 times per week, 2 supervised sessions by trained physiotherapists and 1 unsupervised session for 12 weeks. The 2 supervised sessions consisted of 10 minutes warm-up at 70% heart rate maximum, followed by 4 sets of 4-minute interval walking, running on a treadmill or cycle ergometer at 90 to 95 heart rate maximum, with a 3-minute rest period in between. And after, a 3-minute cool down at 70% of heart rate maximum. This was followed by supervised muscle strengthening comprising 6 exercises for major muscle groups. The unsupervised home cardiorespiratory session comprised of at least 40 minutes of walking, running, or cycling exercise at more than 70% of heart rate maximum. After 3 months, they concluded that high-intensity exercises reduced pain, fatigue, stiffness, and also inflammation in patients with axial spondyloarthropathy. It improved patients' function and cardiovascular health. This debunks concerns that high-intensity exercise might exacerbate disease activity in patients. Then this was followed by another paper, this time looking at how patients perceive their experience with high-intensity exercise. According to patients, supervised high-intensity interval exercise is challenging for both body and mind, but also a manageable exercise mode to improve their physical fitness and general health. The experience strengthened their faith in their own bodies and also changed their attitude and motivation for exercise. Exercise in a social context, under professional leadership, enhanced exercise self-efficacy, and helped the respondents to adhere to the exercise program. Thus, high-intensity exercises can be prescribed to qualified individuals. With regards to setting, studies have been shown that both supervised and home-based programs can benefit patients. However, short-term supervised exercise program may be more effective than home-based exercises at alleviating symptoms, improving mobility, and decreasing disease activity. Reasons for this could be better exercise technique and better motivation, social contact, and communication with other patients. Participation in a supervised exercise program also increases the chance of staying physically active at a health-enhancing level over time in individuals with axial spondyloarthropathy. At 12-month follow-up, almost 70% of the individuals in the exercise group were physically active during leisure time, which is defined as more than an hour per week with moderate or vigorous intensity activity, compared to 30% in the control group. Different physical therapy modalities are used in clinical practice. However, there is very limited number of quality studies on their efficacy in AS patients. In one study, transcutaneous electrical nerve stimulation or TENS provided short-term pain reduction in patients, while in another study, therapeutic ultrasound improved the effect of exercise and reduced pain, stiffness, and disease activity. It also improved mobility of the lumbar spine and improved the quality of life. Prescription of mobility aids such as crutches, cane, walker, or wheelchair is also an important part of rehabilitation, especially in patients with severe disability. For occupational therapy, specific goals are to improve the patient's ability to perform daily occupations, facilitate successful adaptations in lifestyle, and prevent losses of function. Interventions can include training of daily living activities and use of adaptive devices as necessary, joint protection, home and work ergonomics, orthosis, and fatigue management. ADL skills are acquired through repeated practice in a simulated environment. Patients are also encouraged to learn new or modified ways of doing the activities. Adaptive devices such as easy grip utensils, buttoning aids, enrichers or long handles can also be introduced. Certain positions and motions in AS patients can increase the risk of experiencing pain and further damage. Joint protection is based on learning to position a joint in the least painful way with the smallest functional deficit. Even at rest, the position should prevent the development of contractures. An example of this is lying prone twice a day for 20 to 30 minutes to prevent hip flexion contractures. Or when lying supine, suspending the leg over the edge of the bed can promote stretching of the hip muscles. Implementing ergonomic rules at home, workplace, and even during recreational activities also improve the long-term functional outcome of the disease. Some of the recommendations include the following. When working in an upright position, the working surface should be at a height that allows working without bending. A chair should provide support for the entire spine, including the neck, while the hips and knees should be positioned at 90 degrees. Foot pads should be used if feet do not reach the floor, while armrests help to reduce the strain on the cervical muscles. People who spend more time working at the computer, a simple adaptation of the height of the screen and the chair can make a significant difference. A home and workplace combined exercise program for these patients is also an effective intervention program to enhance their physical function, including spinal mobility and pulmonary function. It also reduces work disability through decreased absenteeism and overwork impact, and improved activity impairment. For younger and working individuals who have limited time to exercise, this program is also more practical and time efficient. During the late stage of the disease, orthosis can be used to stabilize unstable spinal segments with present or potential major neurologic deficit, or in the case of complications such as vertebral fractures. Sometimes, a short-term bracing is done during severe exacerbation of pain, although there are no studies supporting this use. In AS with peripheral joint involvement, orthoses are sometimes used to reduce joint load and prevent deformation and contractures. These include orthopedic shoes in the case of major foot deformities, finger orthosis such as shown below in correcting deformations and increasing stability and dexterity, and foot orthosis in reducing pain, improving function, and delaying the development of bunion. Orthosis should be prescribed for a short possible period and always combined with active therapeutic exercise to deter the possible negative effects of prolonged immobilization. Fatigue is one of the most common impairments seen in patients with AS, and this can be addressed by applying energy conservation techniques. These techniques can be done by remembering the 6 P's. Prioritize your daily activities. Plan your daily schedule by alternating heavy with light tasks. Position yourself properly when doing activities. Pace yourself. Keep a slow and steady pace and don't rush. Maintain a positive attitude and use pursed-lip breathing when performing an activity that makes you short of breath. Lastly, patients with AS may have body image issues and suffer emotionally from their altered posture. Likewise, patients may have altered stress response and therefore, the disease itself poses an additional challenge to handling stress. Such patients would benefit from psychology interventions, including one-on-one and group counseling, as well as relaxation and stress management exercises. In summary, ankylosing spondylitis affects the functional ability of patients, resulting to reduced quality of life. Several rehabilitation interventions are available to address these disabilities. An early initiation of a comprehensive and individualized rehabilitation program can help patients maximize their functional potentials and achieve the best possible long-term health-related quality of life. Thank you for listening, and here are my references.
Okay. Thank you very much, Dr. Patricia, Pauline, Remalante-Rayco, and Dr. Anna Tiangco for those very, very nice talks. In the first talk, Dr. Remalante reminded us that the best way really to prevent disability in AS is early and appropriate treatment. No? But it was heartening to see that even when we're a bit late in terms of instituting correct therapy, then it's still possible for us to have some improvement in response. And in the second talk, bigla akong napaupo ng diretso, Dr. Tiangco. Dr. Tiangco highlighted for us very beautifully the interplay between physical impairment and the contextual factors that actually go into disability. And I think she gave us a very exciting lecture in the sense that it seems like our empowered patients are also changing how we prescribe interventions for them. So it's not so, how do you say it? It's not so conservative na pala for our patients with AS, no? So before we start answering our questions in the Q&A box, we would like to recognize our rheumatology colleagues in the audience, particularly Professor Tito Teralba. And we have now 602 participants in this Zoom webinar, plus some patients streaming in Facebook Live. So marami pong nakikinig, and we hope this translates to better care for our patients. Okay, hi Trish, hi Anna.
Hi po, good morning to everyone.
Hi, good morning, ma'am.
Madaling araw na kay Trish, so tama na yung good morning sa kanya. Okay, we'll just have some questions here, no? First, Dr. Trish, in the center where you're at in Toronto, which NSAID do you frequently use? Talagang pinahamak.
So in our center, the top two favorite NSAIDs would be celecoxib and naproxen. So I guess they are favored because celecoxib, of course, has the reputation of being less aggravating to the gastrointestinal tract. And then naproxen can be given either on its own or in the form that is combined with esomeprazole. So those are the top two NSAIDs that we use. Although there are patients who do not respond to these NSAIDs, so we can also give them meloxicam once in a while, and even diclofenac.
But a lot of it is also influenced by what's available in the pharmacy, right? So
yes, exactly.
Because there's a lot of managed care. So I think the bottom line is, you said there's really not much difference among the NSAIDs. So the more important thing is try to see which is safer for your patient in the long term.
Exactly po.
Pero dati meron yun, up in here the Philippines, the combination of a PPI and NSAID, but that has been pulled out already. So we're gonna let Dr. Tiangco catch her breath first. But so we'll have Dr. Trish answer first. Okay, in clinical practice, how should we monitor disease activity daw, Trish?
Okay, so that's a very interesting question. What we do usually at least in the center here, we make use of the BASDAI questionnaire. So this is very widely available in many websites. You can get it for free. You can have apps on your phones. And it's just a 6-question questionnaire that asks about the patient's pain, stiffness, tenderness, and morning stiffness. So that's what we usually use. There's another one for disease activity. It's called the ASDAS CRP, which I think for a time was favored by the ASAS International Society, thinking that it was able to better discriminate patients who had higher disease activity among those with ankylosing spondylitis. But we find that in terms of practicality, the ASDAS is not always the easiest measure to use because it often requires either a CRP or an ESR. So even at our center, we usually go with the BASDAI, and then ASDAS is more for research purposes. But I think on a daily basis, the BASDAI is a very good guide just to have like an objective basis for assessing your patient's disease activity, but also be cognizant because the BASDAI is a very subjective questionnaire. So a lot of the questions there, for example, the first question is about fatigue, like how fatigued have you been for the past 7 days? That can be influenced by a lot of factors, not just AS. So whenever you do get the BASDAI score, just put it in the proper context and then try to see if this is more related to AS or to something else. So in relation to that, if I can add something, I know that the audience is probably wondering how reliable ESR or CRP is in monitoring your clinical activity. They're very useful if they are positive, but if they are normal, it doesn't really mean that you don't have active disease. So just keep in mind that around 40 to 50% of patients with AS can have normal ESR or CRP. So we shouldn't make that like a hard and fast rule that if their inflammatory markers are not elevated, then they're doing okay. So just a reminder.
Well, if the patient is in pain, regardless of what the ESR and CRP is telling you, if you could already fit in the joints, that's still a valid observation. Thank you for that reminder. Here, we one more quick question for Trish before there's a series of questions, I think, for Dr. Tiangco. How fast does AS progress? You answered this in the early part of the talk.
Yes. So in terms of radiographic progression, in the first 2 years of the disease, you can probably see at most 12% of non-radiographic patients become like developing either syndesmophytes or radiographic sacroiliitis on X-ray. And the longer that you observe them, for example, if you follow them for 40 years, let's say 10 years, maybe around 40% of the patients will already have converted to AS. But that's a relatively small percentage. A big chunk of patients still do not progress at all to ankylosing spondylitis.
And it's going to be exciting to see how our biologic drugs are going to change those numbers, especially if we're able to use them early.
Yes.
So the answer to that is valid as of today. Let's see what's going to happen in the next few years.
I agree.
Exciting, no? Yan.
Opo.
Ang daming tanong. Ako, some of these will be answering na lang in the chat, ha? Pero ito muna, highlight ko muna yung mga question. Dr. Tiangco, what exercises can they do at home if they have AS? Because we talked a lot about supervised exercises. What if supervised exercises is not available?
Okay, so for home exercises, they can do simple activities such as breathing exercises, which can greatly help the cardiopulmonary system. They can also do postural exercises as simple as chin tucks, like correcting your head posture, bringing your shoulders back to prevent the kyphotic position. Standing up every once in a while to stretch out those hip and knee muscles. So it doesn't have to be parang bongga or high intensity. Simple exercises, simple joint movements. What we really want is just to keep you moving around.
And if you think of it from a physiologic perspective, no? Ano ba yung kailangan mo para makalakad ka ng diretso? Di ba? Parang, and focus your exercises and ensuring that you're able to keep those alignments. Yan. Okay. So, kanina, Dr. Tiangco, you also talked about what positions they should do, di ba? Or what movements can be done. Meron bang mga dapat hindi ginagawa? avoid?
Position-wise, we don't want positions that would promote, again, flexion. So, like, for example, sitting in a chair, you should prevent chairs that are too low, wherein the hips are forced into flexion. When working on a table, ensure that the height is appropriate so that you do not stoop down. No? Again, it involves correcting the posture and just trying to position yourself upright.
Okay. So, again, remember, functional position is important. Thank you. Ito, hello po doctors, correct po ba na ang psoriasis ay pwede ring magkaroon ng ankylosing spondylitis? Trish, I think this is for you to answer.
Yeah, so that's interesting. So for patients who have psoriasis, pwede po magkaroon ng axial involvement. So it really depends. Some patients may have ankylosing spondylitis later on, but there are also patients na meron pong arthritis from psoriasis, which is what we call psoriatic arthritis. They can also have axial disease. So now there's actually a big debate whether there is a difference between ankylosing spondylitis on its own versus ankylosing or like axial disease that comes with psoriasis. But there are lots of studies that are ongoing, and then hopefully we will have clear answers po sa mga susunod na taon.
Yeah.
But it's
So
possible.
yes, you can have axial involvement in psoriatic arthritis, and even our view of these diseases is really evolving, diba? So here, let's talk about diagnostics. Can AS be detected through blood tests?
Yes, so unfortunately, we don't have a single blood test that can help us diagnose AS. So AS is really diagnosed based on a combination of factors. Of course, you have your history and physical examination. It's also important to take note of the HLA-B27 gene. Although, just a reminder again that you don't necessarily have AS if you test positive for the gene. There's a certain percentage of patients who are negative for that. And then the ESR and CRP, as we talked about earlier, can be helpful if they're positive. But also imaging, X-rays, and MRIs can help with that, as well as the presence of other manifestations like what I showed you in the first slide. For example, if you are diagnosed with inflammatory bowel disease, kung meron po kayong diarrhea and then you see blood or parang sipon sa stool, o kaya po if you have psoriasis, which is the skin condition, or inflammation of the eye, which is what we call uveitis or psoriasis. Uveitis or iritis. And so like the combination of those factors can help your rheumatologist decide whether or not you meet the diagnostic criteria that is not really existent, but like what we use to diagnose patients with axial spondyloarthritis.
So it's really clinical manifestation. You need to have clinical manifestations. The labs are supportive, and the imaging, no, MRI, X-ray, actually show us what's there, no? But
That's right.
it can also be that they will not show us what's very, very mild disease. So, ka-important po talaga yung you consult with your doctor. Let's now go to treatment. This is quick. Is there any role for acetaminophen in the management of AS? Super quick.
No, if because this is an inflammatory type of arthritis, the likelihood of responding to acetaminophen is very low. But we recognize that there are some patients who have many contraindications to different drugs, so we still give it for what it's worth.
Yeah.
But it will not really address the typical
The
symptoms and
inflammation.
signs.
Yes.
Mhm.
So here, what parameters can we use to decide on shifting from NSAIDs to biologics? So when do you switch?
Okay, so I'll think of it in the Philippine context. I think it's applicable for us to do the NSAID trials first. So this is something that we see in the treatment guidelines. So what they recommend is that you give your patients 2 different NSAIDs at least, and then each NSAID can be given on a daily basis at their maximum doses for maybe 4 weeks straight. And then if they have intolerance to that, or if they don't respond adequately to at least 2 NSAID trials, then that can be like a guide for you to start talking about biologics with your patients. So just to share, like in Canada, because they have stricter criteria because they cover the biologics with insurance. They require that the patients also have a BASDAI score of at least 4. The patients should have positive imaging evidence, meaning they should have X-ray evidence of ankylosing spondylitis, or they have inflammation in their MRI. And of course, they should meet the clinical criteria of inflammatory back pain for more than 3 months. So hopefully when we get to that point, we can use these parameters as well to guide biologic therapy. But the short answer is 2 NSAID trials. If they don't do well, then that can be a sign to move on to the biologics.
As long as you're sure that the diagnosis is AF. No?
Right.
Pakaiba pala yung ginagawa. Yan. Thank you for a wonderful lecture. For the patients with AS with active IBD, would IL-12, 23, IL-23 inhibitors be viable if they do not respond to TNF inhibitors? Hard question.
Yes. Oh, yes, that's right. So if the patients have IBD with AS, I think it will be difficult to treat them with IL-12 and 23 or IL-23 alone, because the trials for axial disease with these medications unfortunately failed. But as I mentioned earlier, there is a possibility to explore combinations of biologics. So we do give our patients Entyvio, for example, or vedolizumab, and then ustekinumab in combination with TNF-I inhibitors to patients with AS whose IBD cannot be controlled by the TNF inhibitors. And the good thing about that is that it doesn't really increase your risk of immunosuppression, even if you give these 2 biologics, because they act on different pathways. So that's something that we can consider.
So
Of
that's
course,
going
in
to be next lecture, Trish. Combination biologics, what's the role?
yes.
No?
Opo. Mhm.
So, but that's interesting, no? So we'll have to see where the literature brings us on that. O here, ito, ako na yung sasagot. May bawal po bang pagkain sa may sakit na AS? Ang sagot ay wala. Pero mas maganda if the patient is within a good body proportion. No? Mahirap kung mabigat here. So, one more question for Trish, and then we focus on Dr. Tiangco. Ako na yung sasagot nito, pero yung susunod si Dr. Tiangco. Can AS be cured solely by exercise? The answer is no. That's why we're talking about NSAIDs and biologic medications for these. But here, what environmental modifications will be helpful to prevent independent function for a patient with AS?
Okay, so since there's some spinal immobility, so what you can do is try to put the things that are commonly used within the available reach of the patient. So avoid yung mga high overhead cabinets or super low drawers for these patients. You can also try to minimize clutters on the floor so that they won't have any risk of falling or tripping. Ensure that the height of working tables and working chairs would promote good posture and proper lighting.
Yeah. So in short, try to make things easy for yourself, diba? If or your family member who has AS, hindi yung mapipilitan po silang magwalis sa ilalim ng mababang lamesa. No? So again, parang a lot of it is really logically arranging the household, no? Tapos ito, what about chiropractor? What's your take on the use of chiropractic interventions?
Interventions, yes. The problem with AS is that there's already fusion of the spinal segments. So chiropractic interventions, which basically is like spinal mobilization, might not really help in these patients.
Yeah. Nakakatakot, no? Kung fused yung
Fused na
spine.
siya.
Oo. Tapos
Baka
biglang
ma-fracture.
Fracture ang common complication.
Yeah. make sure you get your patient seen by a rehab medication specialist because a lot of what they prescribe is really individualized, no? So, iba-iba po yung phases, kung maaga pa yung AS, kung late yung AS. So, it's best to get your rehab doctor to see them. Last two questions for Trish. If the patient responds to a trial of NSAIDs, how long would you continue on that NSAID, given if no adverse events?
Yeah, so we do have patients who have been on NSAIDs for years and years, and basically because we don't find any compelling need to move on to a biologic. For example, the BASDAI scores are always low, or we do not see any evidence of radiographic progression on X-rays. So I think you can continue the patients on NSAIDs at the lowest effective dose for them to control their signs and symptoms, but also making sure that the side effects are closely monitored.
As you said, there can still be subclinical inflammation, no? And that's why it's continuously taken. But that's very interesting, no? To quantify how long talaga. Ito, last na talaga to. After a COVID infection, should the AS patient be routinely worked up for myocarditis before resumption of high intensity rehab or exercises? That's for you both.
Actually, any patient who would like to engage in a high intensity exercise training should be seen and cleared by a physician first before engaging in such programs, especially if for those who had COVID-19 infection. So we really don't know yet the full course of the disease since it's relatively new. So it would be prudent to be seen and screened before you do those kind of exercises.
Do the rehab doctors do that as well, Dr. Tiangco? Like they can go directly to you, or do they need to go to an IM first?
We can do the initial screening, and we usually refer to our friendly cardiologist if we see the need that they would have to undergo further tests and diagnostics.
Okay. Do you have anything to add to that, Trish?
I totally agree with that. So it's always prudent to be more careful when it comes to resuming high intensity exercises.
Especially if you have a history of AS, the fact lang that you're entering high intensity exercises even without a COVID infection, I think should warrant clearance with your doctor as well. So thank you so much, Dr. Rayco, Dr. Tiangco, for answering all those questions. I'm sure that our audience learned a lot. We still have 520 participants in the room after 1 hour and 15 minutes. Thank you for our audience for their encompassing, no, and interesting questions. So this afternoon, we learned that to prevent disability in ankylosing spondylitis, early correct intervention is necessary. And when we talk about early correct intervention, that's going to be a combination of pharmacologic and non-pharmacologic treatment, both of which would require the help of our physiatrists and our rheumatologists. So the encouragement is for everybody to get diagnosed early and treated early. It's heartening to hear, however, that even if your disease has already been established, there are still things that your rheumatologists and physiatrists can do for you to prevent further disability and to limit the impact of the disease. Also on the horizon is so much interesting information on newer modes of approaching rehab among our patients with chronic arthritis, and also newer modes of treatment, of combination treatment in the horizon for our patients with ankylosing spondylitis. So thank you very much, Drs. Remalante-Rayco and Dr. Tiangco, for such beautifully delivered lectures. We would also like to thank the Information Management Service Network team of UP Manila and our sponsor, Johnson & Johnson, for allowing this webinar to happen. Thank you all for joining us. We hope to see you again next month on November 24 for another informative and timely lecture regarding very hindi masyadong napapag-usapan pero mahalaga, management of foot pains among patients with arthritis. Have a great afternoon, everyone. And don't forget to answer our evaluation form. Thank you very much. And for our panelists, please stay on for our photo op.